This is the recording for Chapter 17, Bipolar Disorder. It's important to understand the difference between mood and affect. Mood is the emotion that has an influence on how the person perceives the world. This may be anger, anxiety, depression. Affect is the emotional reaction that is associated with that experience. When we talked about schizophrenia, we talked about the flat affect where there was no um, emotion shown. So there's many different types of affects. Mania, alteration in the mood that is expressed by feeling elated, having a inflated self-esteem, being very grandiose, lots of activity, being agitated, and having accelerated thinking and speaking. So sometimes the thoughts come so quickly that the person can't verbalize what's going on in with their thinking. Mania can be part of bipolar disorder, but it also can be part of some other medical conditions and response to some substances, especially um, stimulating substances. So, manic depression was first named in 1913, but even prior to that in the 1800s, it was recognized as an illness. In the 1980, with the new DSM-5, it was termed bipolar disorder rather than manic depressive. So, bipolar disorder affects approximately 4.4% of American adults, um, just as many men as women. Average onset 25 years, occurs more often with the higher socioeconomic classes, and is a leading cause of disability for the middle age group. These statistics come from the National Institute for Mental Health. So this disorder is diagnosed because of shifts of mood from depression to mania. When a person has a manic episode, they are very elevated, expansive, and or irritable. They may do things that they wouldn't have done otherwise. They may not be able to participate in their normal activities, maintain the relationships that they have, and may need hospitalization to prevent self-harm to themselves or to others, and possibly in a manic state, not because they are suicidal, but because of their behavior is risk-taking, and it can cause them to be more risk-taking than you would expect them to be on a usual state. Driving too fast, promiscuous sex, um, substance abuse. Delusions and hallucinations may be part of a manic episode. There's also hypomania, and you see this more in bipolar 2. And hypomania is a milder form. So someone is elevated, but not to the extent that they are when they are um, manic. So bipolar 1. So this person has a full manic episode and also may have symptoms of depression that are episodical. They may also have some psychotic features here. The person with bipolar 2 has major depression and episodes of hypomania. Hypomania is just a um, maybe some exaggerated mood, um, but not to the point that they're having a manic episode. In fact, that's part of the criteria for diagnosis of bipolar 2 is to not have had a full manic episode. There's also a diagnosis called a cyclothermic disorder, and that's where there's a chronic mood issue for at least 2 years, and there'll be periods of hypomania along with depressed moods. They do not meet the severity or duration to meet the criteria for a major depressive episode or a manic episode, but the individual is never without symptoms for more than 2 months at a time. So, substance and medication induced bipolar disorder. Um, because these are because of the use of some type of drugs. Methamphetamine is one that you may see people have a what appears to be a manic episode um, while they're taking that drug. Um, there are also some drugs that may cause changes in behaviors. Those could be the opiates, the sedatives that can do that. There are some um, other medications such as some anticonvulsive medicines, some anticholinergics, anesthesias, um, cardiac medications that can also cause mood disturbances. Steroids are another one that can someone can look like they're having possibly a manic episode that is related to steroid use. So bipolar disorder is another one of these mental health diagnoses that we don't have um, a total answer of what causes this. Um, there is evidence that supports this imbalance of the neurotransmitters, possibly excess norepinephrine and dopamine. Um, Genetics looks like possibly twin studies and other genetic studies have found that it's very possible there is a genetic link in this disorder also. Um, and then neuroanatomical, so some changes in the um, structure of the brain and then medication side effects. So the psychosocial theories, they used to be very big before we had a lot of scientific knowledge about the brain. So those theories are not used as much as it used to be. But there are studies that confirm there is a link between trauma and the development of bipolar disorder, and it is viewed as a disease of the brain. Um, and a biological etiology to this. So the best science we have right now leads us to believe that there is uh, genetic, biological, and psychosocial things that are more likely to have someone have that diagnosis. Bipolar disorder in children and adults, um, it can be very hard to diagnose a child or an adult. Um, and a lot of times, uh, psychiatrists will not want to make this diagnosis until the person is at least closer to adulthood. Um, Prevalence 1% in adolescent bipolar disorders in pediatrics. Um, there is thought to be a connection between ADHD and the development of um, bipolar disorder in youth. Studies found that youth who were given a bipolar diagnosis often had atypical symptoms, mood episodes, chronic irritability, temper tantrums, in young children. There's a higher risk for anxiety and development. So, treatment with medications. Lithium is like a first line of treatment in all patients, in addition to childhood and adolescence. Lithium does have side effects, has quite a few side effects. Um, so a lot of physicians would rather use a anti-seizure medication, um, Depakote here, carbamazine, and the atypical antipsychotics. The atypical antipsychotics can be used when someone is manic. It can quickly kind of bring down that mania. So in children and adolescents, it's been found that the ADHD, being the most common other mental health condition that these children have besides bipolar. Um, Problem with this is those ADHD agents can exacerbate the mania, and so this medication should be withheld until the patients have been stabilized on a mood stabilizing agent like lithium or one of the anti-seizure meds. Or there are some non-stimulant meds that work for ADHD that can be used that may not stimulate mania. And family interventions. Very important to teach both the patient and the family about what bipolar disorder is, how to communicate, and problem solving skills. So, the nursing assessment of someone here. So, there's three stages of mania: hypomania, acute mania, and delirious mania. So, stage one, hypomania. So these symptoms aren't bad enough that are going to cause any problem in their social or occupational functioning. Hypomania will not require hospitalization. Person with hypomania may be overly cheerful, overly talkative, maybe more irritable than you would expect when something doesn't go the way they wish it to be. Their thoughts may be kind of rapid and flow through a bunch of ideas, um, but nothing is going on so much that they can't be distracted and but goal-directed activities may be difficult for them. There may be increase in motor activity. Sometimes they just look really extroverted and sociable, but they are unable to formulate close friendships or relationships in this manner. They may talk and laugh a lot, but sometimes it's very loud and often inappropriate. So, acute mania, there's a marked impairment in their ability to function. Um, Most of the time, hospitalization is required. The person may be very euphoric, um, elated. They seem to be high, but their mood can vary, could be um, irritable and angry very quickly. So their perception is not always um, normal, and they may have psychotic symptoms in acute mania, racing thoughts, rapid movement from one thought to another, um, pressured speech. They may be unable to focus on things because their attention is diverted by anything that's going on. Uh, Hallucinations may happen. Delusions are very common, especially delusions of grandeur. Activity is excessive. They may not sleep. They may not eat. Increased sexual interest. Um, Poor impulse control. And the person who's normally very discreet may become very disinhibited. Then there's a third stage that they call delirious mania. There's severe issues with panic, very labile mood, disorientation. So the person may very quickly go from despair to um, in depression to a very high point without, it doesn't make not because of anything that's happened or the environment or other people. It's just what's going on in their um, cognition. Um, they may be disorientated, confused. Delusions are and hallucinations are very common. They may be incoherent, lots of agitated, purposeless movement, and they can become exhausted, can injure themselves or others, and without intervention, could lead to death. So, a nursing diagnosis, risk for injury related to the extreme hyperactivity, the agitation, um, potential injurious behavior. And we got to remember going back to Maslow. These people may not be eating, they may not be sleeping, they may not be drinking water, they may be doing things that are not uh, appropriate for the environment, and we can't really treat the symptoms of bipolar disorder until they can kind of get calmed down. That's one of the reasons why the atypical antipsychotics are important, because they can very quickly bring that agitation down and the hyperactivity, and then make it easier to deal with the problems with the bipolar mood swings. Another nursing diagnosis you might see, risk for violence either to themselves or someone else. Imbalanced nutrition because they refuse or are unable to eat, have a loss of weight, possibly dehydration. Disturbed sensory perception, um, impaired social interactions, and insomnia are all nursing diagnoses that you may see with these type of patients. So how do we measure outcomes for the client? We want them not to have any physical injury, not to harm themselves or others, not to be physically agitated anymore, so that eating and sleeping, um, and they can verbalize the correct interpretation of the environment, that there is no hallucinations, and their delusions are, um, if not gone, at least manageable at that point. This slide is just a continuation of this. Um, no behavior that looks like hallucinations, able to accept the responsibility for their behaviors, not manipulative, interacting appropriately, can sleep and sleep 6 to 8 hours a night without medication. That might be farther down the road than the initial. Um, we want to make sure if there is a risk for violence, either self-directed or others, that we remove dangerous things. Um, these person, these people may not be suicidal, but they may do things that can harm themselves or someone else simply because of their agitation and thought processes.